Hello everyone, we are starting with hyperuricemia. In this session, we will mostly discuss about the treatment of hyperuricemia. Okay, so what is hyperuricemia? Simply, what does it mean by hyperuricemia? So it's just that the blood level of uric acid is increasing. So according to Harrison, you could see that in men the uric acid level, if it is going above 7 milligram deciliter, and in women if it is going above 5 milligram per 5.7 milligram per deciliter, they are called hyperuricemia. So during evaluation of a hyperuricemia case, the most important evaluation is the uric acid secretion in the urine in 24 hours. That's very important. So we'll come to it later. Okay. So what are the etiologies of hyperuricemia? There are many causes. There are primary causes and secondary causes. Okay, primary causes and secondary causes. First, when you are discussing about the primary causes of hyperuricemia, you should understand that the error of purine metabolism. The patient is born with the congenitally the problem with the purine metabolism. First, it is Leishman-Hand syndrome, which the HGPRTS deficiency, phosphoribosyl transferase, hypoxanthine guanine phosphoribosyl transferase deficiency. Next one is the glycogen storage disease. In such cases also there is a inborn error of purine metabolism. The uric acid production will be high. Then we'll discuss about the secondary cause. In secondary cause, one is overproduction. More uric acids are produced. Second one is decreased secretion or excretion by the kidney. The kidney is not properly secreting or excreting the urine from the body. Okay. First, we'll discuss about the overproduction. In overproduction, there is increased cell turnover, which means what? The cell will have a nucleus. Most of the cell will have nucleus except platelets. You have a DNA. Your DNA is simply made up of purines and pyrimidines. So purine. So when you take a when in case of leukemia, what do? The cell will proliferate and then go for die. The die, there are more purines are produced, which turns into uric acid. That forms overproduction of uric acid. Okay. Next is tumor lysis syndrome. Here you have the proliferation of cells. Eventually they get die, so more uric acids are produced. Next is myeloproliferative disorder. Myeloproliferative disorders are bone marrow proliferative disorders. Similarly, it will proliferate and die because all the DNA contain these purine-rich products. Next is anemia. Which one? Hemolytic anemia or hemolytic processes. Hemolysis causes increases the uric acid in the blood. Psoriasis, increased cell turnover. You know, psoriasis usually take 28 days for the cell to come from the baseline to here. But in psoriasis, it come earlier and will get destroyed, peeled off. In such cases, the urea will also get increases. And then, like we all know, exercise during these cases also causes. Next, we'll discuss the decreased excretion of uric acid. Okay, why there is a decreased excretion of uric acid? We should always blame the kidney. The kidney is probably the culprit for the decreased excretion of uric acid. Okay, the kidney is the problematic thing here. That is nephropathy. Sometimes it can cause lead poisoning, alcoholism, ketoacidosis, hypothyroidism, like that. In drugs, mostly diuretics. You should know the people, the patient, especially the hypertensive patient who are taking diuretics, there will be the uric acid level will be very high in such patient. Even if you do mini test or these and that, or you treat the patient also, the level of the uric acid will be a bit elevated because of the thiazide diuretics, which is the loop diuretics, which block one sodium potassium ATPase. So one sodium, one potassium to chloride transporter. This is blocking this channel, and that's why the uric acid levels are high. Then aspirin at a low dose. Okay, the niacin at high dose. In TB cases, the pyrazinamide. The pyrazinamide is a drug which is used in the treatment of TB. It will cause decreased excretion. Okay, it will cause a decreased excretion. Decreased. Decreased excretion of uric acid. Then chemotherapy, tacrolimus, cyclosporins, NSAIDs like salicylates. The classification of hyperuricemia by pathophysiology. Okay, pathophysiology. Simply we have tailed the urine overproduction, decreased urine excretion, and we have combined mechanisms. It's clearly given in the Harrison textbooks. See the overproduction we discussed, production, most of the cancerous production, proliferative diseases. Okay, myeloproliferative, like that. Then lytics process, hemolysis. See, then we told HTPRTS deficiency, Leishman-Hand syndrome. Then there are psoriasis, increased cell turnover. Then polycythemia, production more. Rhabdomyolysis, obesity. In some obese patient, we could see that the patient is having hyperuricemia, urine-rich diet. Then decreased uric acid excretion. Excretion, we blame always the renal problem, renal insufficiency, then kidney problems. Okay, in diabetic insipidus, hypertension, very important. See, most of the patients are hypertensive. So you have to think that when the uric acid is high, beware of it because it can cause renal stone, it can cause renal failure, and renal failure itself can cause hyperuricemia. Both are interconnected. Okay, we already discussed about the drugs like salicylate, diuretics, alcohol, ethambutol, paracetamol, cyclosporin, tacrolimus, like that. You just acidosis, Bartter syndrome, just Down syndrome. You just memorize all those things and some combined mechanisms like glucose 6 phosphate deficiency, fructose 1 phosphate aldolase deficiency, like that. Okay, we are coming to the investigation. Okay, in investigation, what we do is we know that many problems like hypertension, obesity, many problems can cause hyperuricemia. So you check the serum uric acid level whether it is more than 7 in male or 5.7 in female. 5.7 in female. Okay, it can be normal during acute attack of gout. Okay, in there is acute attack, it can be normal. You just check the complete blood count and peripheral smear whether to rule out the leukemia or polycythemia, like that. Then the lipid profile, because obesity, of course, it can cause urine, whether the uric crystals or like after the thyroid function. So quantification of urine, that is, as we said, 24-hour quantification is required, 24 hours per day. See, the quantification can just discriminate whether it is overproduction of uric acid or whether it's decreased excretion of uric acid. Okay, you see that a person who is on purine-free diet, whose renal functions are normal, will excrete normally 60 milligram of uric acid per day. Okay, so if the person is excreting more than 60 milligram of uric acid per day, that means it is overproduction. Okay, like that, more than 600 milligram. Like that, if the person is excreting less than 600 milligram per day, it is decreased excretion. Very less. Okay, so if it is in a regular diet, if you're facing chicken, beef, like if it's a regular diet, this cutoff is almost 800. So don't take it as a perfect value, consider as a range. Okay, then you told that NSAID is the treatment part. This comes to the treatment part. This is the treatment part of a case of an acute gout attack. We'll treat with NSAIDs, naproxen, indomethacin, to relieve the pain. Then we use colchicine. Colchicine is a drug, we use 0.5 milligram probably, but in most cases, acute attack, we use a 1 milligram loading dose, followed by we use 0.6 milligram hourly till the patient develops vomiting or diarrhea. Do not cross more than 3 milligram per day. Okay. So then we use a, 0.5 milligram 8 to 10 12 hourly, that is TDS or BD. Just monitor CBC, LFT till symptoms normal for 3 months. Okay. Then raspberry case, which is the recombinant urate oxidase. It is also used in hyperuricemia. Okay, due to tumor lysis syndrome in patient with lymphoma and leukemia. Raspberry case. So dose is IV 0.2 milligram per kg once day for 5 days because it's a urate oxidase. Then we have in chronic cases we use allopurinol. There are 100 milligram, 300 milligram. Allopurinol, the xanthine oxidase inhibitor, which block this step, preventing the formation of uric acid. The dose is 300 milligram single dose. Then we can slowly increase up to 2 gram per day till the serum uric acid is less than 5. Okay, but we should be cautiously used in case of renal impairment because if it is severe renal involvement, it should not be used. Okay. In febuxostat, we have doses like 40, 80, 120. We can start with 40 milligram OD. But the problem with febuxostat is it should be chronic therapy. Whenever you stop the febuxostat, there will be rapid rebound increase in increase in uric acid. Okay, so it's less adverse than hyper. So then we discuss about the diet. Okay, you If the uric acid is high in your blood, one thing you can do is you increase the water intake. You increase the water intake. If it is high purine foods should be avoided, like what meats, especially red meats like beef. Okay, the seafoods, most seafoods like crab or sardine, like that. And meat extracts, gravies, yeast extract, bakeries, beers, alcohol should be avoided. Okay. Then protein-rich foods like vegetables like beans, peas, lentils, oatmeal, spinach, asparagus, cauliflower, and mushroom should be avoided. Okay. Then another treatment in case of an acute attack, they showed that alkalization of urine with a soda bicarbonate or acetozolamide. It's a point that is given in the Harrison to increase the solubility of uric acid. Okay. Then potassium citrate that is 30 to 80 millimoles per day orally is another alternate therapy for patient with uric acid stone alone. So that's for the class. Thank you for listening. Have a nice day.